Now, I don't want you to walk out of this lecture and see a patient with pericardial TB and miss a case of cardiac tamponade. So we're going to briefly review this here, although there will be separate lectures on tamponade you'll receive throughout the course of your training. So TB pericarditis is the most common cause of cardiac tamponade in both Africa and Asia, and it's more frequently seen in patients with TB who are HIV positive. So in an HIV positive patient, who presents possibly with signs of pericardial TB, you should have a high index of suspicion that tamponade may be coexisting. If not identified promptly and treated, this condition is fatal, and I've certainly seen cases of this. Pericardiocentesis is a life-saving intervention, and it's essential in all patients who have tamponade. In clinical studies from sub-Saharan Africa, the proportion of patients with TB pericarditis who present with tamponade has ranged anywhere from 20 to 90%, depending on the selection of patients and the definition of tamponade. But it's not uncommon. We're taught in school that classical clinical findings in tamponade are Beck's triad, which include raised JVP, hypotension, and muffled heart sounds. And although I do want you to always look for these things in a patient you suspect of having pericardial disease, this constellation of clinical findings typically occurs in the setting of rapid accumulation of a large pericardial effusion, like in trauma, but is typically not the case with TB pericarditis, although it can be. In one retrospective case series of patients with TB pericarditis from South Africa, the most common clinical findings among patients with tamponade were dyspnea, tachycardia, and tachypnea. Elevated jugular venous pressure was seen in about 50% of patients, and only about 30% had diminished heart sounds. Given that imprecision of physical exam in identifying cardiac tamponade, especially when it's subacute, cardiac ultrasound is really your best diagnostic modality to identify this and should be done in all patients in whom you suspect to have TB pericarditis as early in your evaluation as possible in order to exclude tamponade. Ultrasound will show you typical features such as collapse of the right ventricle and the right atrium. Those are the typical features of tamponade on ultrasound. If a patient, especially an HIV positive patient, is presenting with severe dyspnea, severe tachypnea or hypotension, and an echocardiogram is not readily available, I would recommend you do a pulsus paradoxicus. And if it's elevated more than 12 millimeters, then tamponade may be present. Ideally, you would still want to get a cardiac ultrasound prior to performing emergent pericardiocentesis, because constrictive pericarditis can also elevate the pulsus paradoxus. But in the setting of an emergency, this would be one piece of confirmatory evidence that would alert you that an emergent intervention may be necessary for a patient.